In gynecologic oncology, we're seeing pivotal shifts driven by emerging data. The TRUST study is reshaping our thinking on primary debulking surgery versus neoadjuvant chemotherapy in advanced ovarian cancer, emphasizing individualized treatment. Meanwhile, the SHAPE trial is redefining surgical extent in early-stage cervical cancer, suggesting that less radical approaches may offer equivalent outcomes. And in recurrent platinum-resistant ovarian cancer, the MIRASOL study highlights the promise of antibody-drug conjugates like mirvetuximab, offering new hope for targeted therapies. These trials collectively underscore a move towards more precise, patient-centered care. Thank you for joining us.
Welcome to Baptist Health Doc to Doc, a podcast built for innovation and collaboration by physicians for physicians.
Hello, I'm Dr. Thomas Morrissey, Director of Gynecologic Oncology at the Eugene M. and Christine E. Lynn Cancer Institute, part of Baptist Health at Boca Raton Regional Hospital. And joining me for discussion is Dr. Ryan Kahn, a fellowship-trained gynecologic oncologist at Baptist Health Miami Cancer Institute. Morning, Ryan. Thanks for joining me.
Thank you, Dr. Morrissey. It's a pleasure to be here.
Very good. So they've given us the opportunity to discuss some of the advances and new topics in treatment of gynecologic cancers. Again, by the introduction, we'll start with the TRUST study results. Again, this was a study that dealt with initial treatment of ovarian cancer, which typically, and the standard treatment is to try to do surgery first and remove as much tumor as possible. But in certain situations where patients present with advanced tumor, sometimes if it's unable to be all removed at the time of the first surgery, another strategy is to give chemotherapy first to kind of shrink the tumor to allow surgery to take place later in what we call an interval debulking. And so this study was using a strategy, kind of randomizing patients between trying to do surgery first versus giving chemotherapy first in advanced ovarian cancer patients and see which strategy worked better.
Yeah, definitely. So this was a groundbreaking study recently presented at the ASCO conference in Chicago in 2025. So everybody was excited to see these results. You know, we've known for about 2 decades now that doing cytoreductive surgery and achieving complete gross resection of all the visual disease tends to put our patients in the best prognostic group. The controversy or the question always was, do we start with surgery or do we start with chemotherapy? And that's what the TRUST study, like you mentioned, looked to address. So this was at expert centers from around the world, similar to here at MCI expert centers where they do comprehensive surgery and have recovery units and are capable of performing these big surgeries. So it looked at over 650 patients, like you said, randomized half to primary cytoreductive surgery up front, the other half to neoadjuvant chemotherapy, followed by interval cytoreductive surgery. So what they found was, as we expected, the patients who did the best were those who achieved complete gross resection of all visual disease at time of surgery. The progression-free survival, so the time it took for the disease to come back, was significantly better in the patients who had the primary cytoreductive surgery as compared to neoadjuvant. What was interesting was the overall survival was also better in the primary cytoreductive surgery group. However, it wasn't statistically significant, and there could be several reasons for that. I think the most important things to take away from the TRUST study is, one, the timing of surgery may still make a difference, maybe not as much as we thought before, but the patients who did the best had primary cytoreduction up front with complete gross resection. That was seen, that was definitely clear. And I think another takeaway, and what you could read between the lines, is the most important things are the quality of surgery that the patients receive and the selection of where they have their surgery. So I think those were the major takeaways from the TRUST study. So I think, neoadjuvant with interval cytoreduction is still on the table for patients, like you mentioned, who may be warranted, whether it's extent of disease or comorbidities, active DVTs, things like that. But primary cytoreduction with complete gross resection, when feasible, should be offered to our patients as well.
Absolutely. Yeah, I think it reinforced kind of what we've been doing for many years. Kind of one of the dogmas of treating ovarian cancer patients is to try to gain an optimal cytoreduction and remove as much tumor as possible, ideally for no gross residual disease, and then those patients had the best prognosis. So this further kind of reinforces that. But also, from the other side, there are certain patients that aren't candidates for surgery, either due to concomitant medical issues, sometimes age, sometimes access to care, and that if they do undergo neoadjuvant chemotherapy and have an optimal attempt at interval surgery, that their overall survival isn't statistically significant. Again, it's a little bit less in the study, but that overall, the fact that you couldn't have an initial surgery or weren't able to have an initial surgery doesn't, put you at your entire disease course at a significant disadvantage compared to patients who are able to have initial surgery. But obviously, again, we tried to also reinforce to the community that if you have a patient with a known or suspected ovarian cancer, peritoneal cancer, or findings consistent with that they need to see a gynecologic oncologist at a center that has the ability to make the maximal attempt at trying to do an initial surgery, because that gives your patient the best overall outcome.
Absolutely.
All right. Again, so we have 5 topics to go through today, and any other things that come up. So we'll move on to the next study that we mentioned earlier, was resectability scoring, to try to determine which patients are best suited for a primary surgery attempt versus neoadjuvant chemotherapy. And again, the trial we discussed before, the trust trial was randomizing patients in this situation. And then we try to figure out, if there are patients that are, if we try to do that primary maximal debulking attempt, whether we'll be successful at that or not. And so what we'd like to do is make sure that the patients that we take for that maximal attempt, we're actually able to achieve that objective, because if you do a big operation, but you're only able to remove 80 or 90% of the tumor, you're really not helping them very much based on data that we have when following those patients. And so if there's a way to kind of predict that better before going to the operating room, it may be helpful to avoid what they call futile laparotomy surgeries or futile attempts at optimal cytoreduction, and may help us kind of streamline care a little bit. So I know that was something that you participated in. So
yeah, definitely one of research passions of mine. And yeah, like you said, I wish we had a crystal ball where we could see this patient could definitely get a complete or optimal cytoreduction, and that would make it a lot easier for us as surgeons to triage our patients. Unfortunately, CT scans, PET scans are very good and very accurate, but sometimes they do miss microscopic disease or disease on the bowel serosa, disease in the peritoneum, as well as certain areas. So what we looked at, while as a fellow at Sloan Kettering, one of the studies we looked at was modifying and perfecting a resectability score algorithm that used patient clinical characteristics as well as radiologic variables with a synoptic report from a radiologic team. And what we were able to find was we did a scoring system with a threshold of high risk of not achieving complete gross resection versus low risk. And we're able to use that to triage our patients. And we found it was highly sensitive and specific for doing so. We had a complete gross resection rate over about 80% and a futile laparotomy rate of less than 5%. So, we're never going to be perfect in determining which patients could go for primary cytoreduction versus neoadjuvant, but we're going to try to get as close as we can. And that's what this study tried to do. And it's a real exciting future as technology is getting better, as artificial intelligence and the ability to mine through large data with the use of technology will only make this better and will only get better in the future. And I look forward to studying this here as well.
Great. Yeah. I mean, in terms of, that study was obviously a lot of optimism reading that study, because, if we can kind of do a laparotomy virtually, but with PET scans and like that to kind of get the same findings. But what's been done, more standardly kind of around the world is to assess patients laparoscopically, to make an incision, take a look with a camera, and with a couple of investigators reporting their scoring systems that would predict whether or not you can do optimal cytoreductions in those cases. So often, one of the other methods to go about this is to go for laparotomy, make an assessment, make a decision whether or not you can complete a gross cytoreduction, and also take samples which nowadays can be helpful for tumor analysis, genomic analysis, and to help us determine targets for treatment as well. In terms of how you treat patients with this, in terms of we always get preoperative scans and such, but is that something that still is part of your armamentarium, is to do a laparoscopy to make the final decision?
So I think it's really resource and facility dependent, depending on where you're being treated. Laparoscopy with biopsy and being able to assess either with a Fagati score or different scoring systems when looking in is also a standard of care. And yeah, it's definitely something in the armamentarium of a lot of the physicians. What we found throughout the 4 years of doing the study, there were questions whether very low score was almost a home run where we know we would definitely get a CGR. But a lot of the times it was in that gray area of getting into the 5, 6, 7 mid threshold. So yeah, a lot of the times we did do a diagnostic laparoscopy to take a look. And like you mentioned, getting a biopsy, because that's going to be key for treating the patient in a timely manner if they do undergo chemotherapy, knowing exactly what type of cancer they have, whether it's from the ovary, the uterus, what type of ovarian cancer, targeted markers as well that we could use now we'll talk about more in the upcoming topics, targeted therapies. But yeah, absolutely. Doing a diagnostic laparoscopy is definitely one of the tools as well.
Right. So yeah, and in terms of, like I said, some of the discussions about that study, which was a very well done study, and again, you had some dedicated radiologists who take care of mostly gynecologic cancers, who are pretty good at looking at things, and so whether or not every hospital is equipped to make the same predictions, and so like I said, it's something that should be studied and see if we can do it. But I think that for most patients, at hospitals that don't have the expertise in terms of this, that I think the standard probably will still be to try to get the patient to a gynecologic oncologist to perform a laparoscopy or an assessment, or at least have that gynecologic oncologist look at the scans and say, listen, between my exam and these scans, I don't think that we're going to be able to do a gross initial side reduction, in neoadjuvant chemotherapy is the way to go. Yeah, absolutely. Very good. So moving on to from ovary cancer to cervical cancer, discuss kind of the a trial that was reported last year in terms of treating cervical cancer and trying to reduce the radicality of surgery. So with cervical cancers of a certain stage and type, usually the standard treatment would be something called a radical hysterectomy, which removes the uterus and the cervix, as well as a large portion of the vagina and what's called the perimetrium, which is to the right and left of the uterus, as well as some lymph nodes. And that surgery sometimes can cause some side effects afterwards, because it may cause some denervation of the bladder and kind of has increased risk of short and long-term side effects compared to what we call a simple hysterectomy, where you just take the uterus and the cervix and the tubes and ovaries out without that extra tissue around the uterus and around the bladder. In terms of trying to reduce the amount of surgery for patients with smaller tumors, there's a trial called the SHAPE trial, which is done to try to look at early cervical cancers for tumors that were on the smaller side, to see if treating with again, a less extensive hysterectomy called a simple hysterectomy with assessment of the pelvic lymph nodes would be inferior or equivalent to doing a bigger surgery with more side effects. And so it was interesting to see the results of those trials.
Yeah, absolutely. Like you said, I think we're always trying to get better in what we do and do better for our patients. And sometimes that's dialing down the surgery and seeing that they may not need this large radical hysterectomy. Maybe a simple will do. So yeah, this isn't for all patients, like you mentioned, in the select patients, so 1A2s and 1B1s, so less than 2%. I believe it was 10 millimeter depth of invasion or less than 50% invasion into the cervical stroma on MRI, and lower risk histology, so squamous adenocarcinoma or adenosquamous, so excluding some of the higher risk ones like gastric, neuroendocrine, or clear cell. But yeah, in these low risk cervical cancers, they found that performing the simple hysterectomy, and it is important to note that this was done at the discretion of the discretion of the surgeon was open versus minimally invasive, which is a a conversation in itself. But yeah, they were randomized half and half to simple hysterectomy, half to radical hysterectomy of, I believe it was about 700 patients or so. And they found that, yeah, doing this simple hysterectomy when it came to cancer survival, overall survival was non-inferior. So it was no worse than doing a radical hysterectomy. What they did find, and like you mentioned and alluded to, was yes, performing a simple hysterectomy did lead to less urinary issues such as urinary retention, bladder injuries, and less long and short-term complications as well. So this is another thing that we're seeing over time. This could be a great option for our patients and kind of almost standard of practice setting where patients who come in now with these low-risk cervical cancers may not need this large morbid surgery. They may get away with requiring more of a simple hysterectomy as well.
Yeah. So again, that's it is very welcome data for us to try to. And I actually treated a patient this week using that data, but in presenting the data to the patient to make sure decision making, as you alluded before, kind of not to get too off topic, and this could be a whole show in itself, but in terms of the use of minimally invasive surgery for cervical cancer has been somewhat controversial based on a couple of large studies that showed that there might be a slight increase in the risk of recurrence in patients who had laparoscopy versus open surgeries. And so for this, at least with very early cancers, again, these tumors are less than 2 centimeters and fairly early in this group, it didn't appear that laparoscopic versus open approach in this study affected your risk of recurrence. And also in this study, there were no specific protections in terms of treating the cervical tumor, whereas there's new studies available, including one that's being done at one of the sites is Baptist Health, the ROCK trial, where we're doing radical hysterectomies, laparoscopic versus open in a randomized trial. But as part of that trial, they're doing things to contain tumor spillage, which involves kind of making sure that the cervical tumor has no access to the peritoneal cavity by either stapling the upper vagina or using a cerclage. In this case, this study, there were no special containment procedures, and it didn't appear that laparoscopic versus open had any difference there. So that was also welcome news from that standpoint. But we're, again, we always talk about kind of the studies to try to advance knowledge and advanced care. And again, Baptist Health, Miami Cancer Institute participating in that study to see whether or not we can safely perform radical hysterectomies laparoscopically without affecting prognosis. And again, that would be a much better option for patients as far as recovery and shorter stay.
Definitely. And pain management as well. Definitely. Yeah.
Very good. Moving on from cervical cancer, we're talking about one of the very welcome things that's happened in the last couple of years is the evolution or kind of advent of using checkpoint inhibitors in the frontline setting for endometrial cancers, with 2 large studies in endometrial cancers using pembrolizumab or also dostarlimab in combination with Taxol and carboplatin, which had been the standard therapy for advanced uterine cancer after surgery. And showing a very large benefit, especially in patients with mismatch repair deficient tumors. So those 2 studies, again, were the results of those were very quickly assimilated into our practice, and we've seen a huge difference already.
Yeah, absolutely. Practice changing studies. And it's interesting. They both came out around the same time and were presented at SGO several years ago, now widely utilized in practice. Like you mentioned, for decades, we've been using carboplatin and paclitaxel for uterine and advanced and recurrent uterine cancer. So it's a nice welcome and setting the footprint forward for more targeted therapies. And what dostarlimab and pembrolizumab do is they're PD-1 inhibitors, like you mentioned, checkpoint inhibitors, where they modulate the patient's own immune system to try to get around the immune evasion that some of these cancers do to try to hide from your own immune system, kind of unlock it and allow the chemo as well as your own immune system to fight the tumor as well. So with Ruby using dostarlimab, they combined dostarlimab with the carboplatin paclitaxel, like you mentioned, and followed up with maintenance of dostarlimab for up to 3 years, and found, like you mentioned, a significant survival benefit. And it's very stark when you look at these Kaplan-Meier curves, the difference it made, not only in the overall population, all comers, but specifically in the mismatch repair deficient tumors as well. So it is important to note that it is available for all patients and very effective in all patients, and even more so in some of the DMMR patients as well, as seen with pembrolizumab. Once again, mirroring the Ruby study with GY018, where they gave the pembrolizumab and followed up with up to 2 years of maintenance with the pembro. And once again, seeing a stark difference in the survival. And it is exciting when you're at these conferences and you see such a gap between the survival curves where these medications are making a difference for our patients and extending survival, whether it's progression-free or overall. So very exciting things. And I think it's setting like I mentioned, it's setting kind of the blueprint for what the future of our immunotherapies and chemotherapies, and that these GYN cancers can respond to them.
Yeah, absolutely. And again, having practiced for a little bit longer, in terms of, for many years, we just didn't have very, very good options as far as treating endometrial cancer, Taxol carbo being the best what we had, and really no options that had a very high response rate. So to be able to help these patients and again, especially see really dramatic responses in the patients that are mismatched repair deficient, with years long survivals. And again, there may be some that we're waiting longer and longer for them to recur, where they're just not. So even in recurrent disease, we're seeing responses. So it's very promising. And again, kind of opens the door to see, how can we integrate these further? How long do we need to use them? Are the new medicines that are going to be available? So it's an exciting time for endometrial cancer. In terms of talking about checkpoint inhibitors and immune modulation, again, we use these types of medications in treating our other cancers as well. And then again, using it in cervical cancer is something that we've done more recently, with some benefit being shown from using pembrolizumab with radiation, with primary chemo radiation. So usually we have a cervical cancer that are too large to do an operation, usually more than 4 centimeters, or involving kind of areas outside the cervix. Often the treatment is primary chemotherapy with radiation, and adding pembrolizumab to that regimen has shown a increased efficacy as well.
Yeah, absolutely. And like you mentioned, the more tools we have as physicians to help our patients, the better. And what we're seeing too from a lot of these immune checkpoint inhibitors like dostarlimab and pembrolizumab, very well tolerated. There are side effect profiles and adverse events we do look for, such as like thyroiditis, colitis, other things like that in rare instances. But compared to some of the more conventional chemotherapies, on the majority, patients are better tolerating some of these medications as well.
Yep, very much so. To move on, keep things moving here. So in terms of discussing other new medications, there's a newer medication called an antibody-drug conjugate, where you have an antibody that targets the tumor, and it carries a payload of a chemotherapy drug and releases that to the cell that it attaches to, which hopefully makes less toxicity because the chemotherapy is going exactly where you want it to go. One of those medications is called mirvetuximab, and it was studied in a study called the MIRASOL study in recurrent platinum-resistant ovarian cancer, which is a group that after kind of our initial chemotherapy stops working and the tumor is growing, we haven't had very much success in terms of medications or any kind of treatments that will really control disease very well. A few years ago, with the advent of bevacizumab, using that with oral Cytoxan, was kind of one of the first things that showed any appreciable response rate in this group of patients. And then we've tried a few things since then with using Avastin or bevacizumab in that group. But also now using the antibody-drug conjugates like mirvetuximab.
Yeah, very exciting time for ovarian cancer as well. So like you mentioned, in the upfront setting, usually most ovarian cancer, especially high-grade ovarian cancers, do respond very well to platinum-based therapy. A majority will respond. Unfortunately, there is a certain number that do come back and recur over time and become more resistant to chemotherapy drugs over time. And yeah, like you mentioned, there weren't a lot of good options for our patients. So antibody-drug conjugates, I think, are definitely the future as well. And like you mentioned, it's almost like a lock and key, where seeks out the cells that highly express the alpha folate receptor, which ovarian cancer cells majority of the time do, especially with high expression. These were seen to have very good results. So what it does is it picks out those cells and leaves out or doesn't address the other cells, such as your normal cells that you don't want the chemotherapy or the antibody-drug conjugate going to. So some of the side effect profiles are very different and less severe in a lot of cases. There are certain things we look for, like eye toxicity, sometimes also immune events that we do look. But once again, pretty well tolerated with mirvetuximab. And so, this was used for platinum-resistant ovarian cancers that have received 1 to 3 previous treatment modalities in the past. And this opened a new door in patients that weren't responding to much of, less than 15% response rate. Now we have response rates of greater than 40%, or about half the patients are responding to the mirvetuximab. The select patients with high alpha folate receptor positivity. So once again, a very exciting time for our patients. And I think more coming on the way as well. But I think once again, this is kind of getting to the overall theme and what we're talking about in going to a gynecologic oncologist and an experienced center where they know to test for these things, where they could give you these options. And, I think that's so important for the patients to realize.
Yeah, no, very much so. And again, in terms of these medications, it's helpful, especially the new medications, to have a physician who's becoming very experienced kind of very quickly to look for these side effects. Like I said, the mirvetuximab has kind of some unique side effects that which can be some eye toxicity and things like that you need to be on a special program of eye drops and have an ophthalmologist look at the eyes every couple cycles to make sure that we're doing everything we can to reduce toxicity. So to have kind of some places done that before is a good place to be. And also with the mirvetuximab, you talked about kind of the patient group in the MIRASOL study where patients that had a very high level of folate receptor on their tumors, whereas they've done some other studies to show if there's even a lower level of folate receptor using the mirvetuximab in combination with bevacizumab, that there's a good response rate in those patients as well. The other thing from having patients on this medication is the patients who tend to respond tend to have a very long response. Yeah. And so, which again is kind of new for us and a very welcome thing for treating ovary cancer, because usually with the medications that we had before, we may find a medication that will respond and control disease for a little while, then that will become resistant to that medicine. Yeah. So we switch flavors and use another medication, and then that will give us a response, but it's usually shorter than the previous medication's response. Yeah. Whereas with the mirvetuximab, we're seeing patients that weren't really responding to other things that we were trying, and then had a very good response that had a long duration. So again, it's been a good advance for us. They're talking about final thoughts now, but just before, I always like to mention these that the importance of HPV vaccination, of course, which is again is probably the biggest intervention that we've had, and again with cervical cancer. In the advent of the Pap smear, significantly reducing, the burden of cervical cancer in the United States, and now with the HPV vaccination, significantly reducing the risk of cervical dysplasia, which is the precursor to cancer. We've already seen a significant decrease in the amount of patients that are dealing with these problems, and again, a vaccine that's safe, very effective, and recommended for everyone between ages of 9 and 26, both males and females, and males to help reduce the risk of anal cancers and head and neck cancers. But a very important intervention that again is one of the biggest advances that we've had in the last 20 years as well.
Yeah, absolutely. Study after study has shown that the HPV vaccination saves lives across the population. And we are seeing it even, in our own gestalts, we're seeing less and less patients come in with some of these more serious cervical cancers, which, is a great thing to see. So keeping up with the, I would say the public health push for it is so important. And for the patients to take note. Absolutely.
Great. All right. So as we look from everything from the TRUST study to SHAPE and MIRASOL, it's clear that we're moving into a new era of gynecologic cancer care. We're learning when to scale back, when to be aggressive, and how to tailor treatments in smarter, more targeted ways. It's not just about survival anymore. It's about quality of life, long-term outcomes, and making each decision count. These trials are giving us the evidence to evolve, and that's an exciting place to be for both clinicians and our patients.
To find out more about the topics covered on Baptist Health Doc to Doc, please visit physicianresources.baptisthealth.net.